Good evening and welcome back to the Canadian Concussion Centre's webinar series, which is sponsored by LIUNA, the Labor's International Union of North America. My name is Leslie Rattan, and I'm really pleased to be moderating our webinar series, which was developed for individuals that have suffered from concussions, their family, as well as healthcare providers. If you've been with us before, you know that our sessions focus on various aspects of concussion, and we typically will start our sessions with a half an hour or so expert speaker talk, and then you're able to get your questions answered in the second half of the session. And our webinar series runs every other Tuesday evening from 6 to 7 p.m. So for this evening, I'm really pleased to welcome back Dr. Michael Hutchison, who is going to be talking to us about return to athletics, principles, and who to see. Oops. There we go. Okay. Professor Hutchison is an associate professor and director of the Centre for Sport-Related Concussion, Innovation, and Knowledge at the University of Toronto, where he oversees an interdisciplinary clinical research team of health professionals for sport or physical activity-related concussion. He holds a PhD in Rehabilitation Science and is a registered kinesiologist. And present research focus is in the areas of neuroscience, kinesiology, and rehabilitation. He also holds scientist positions at the Keenan Research Centre for Biomedical Science of St. Michael's Hospital, and also for the National Hockey League's Players Association, the NHLPA. So with that, I'm going to turn it over to Dr. Hutchison.
Thank you for everyone this evening taking the time out of your evening to kind of go over this talk, and I look forward to sharing this information with you. So hopefully everyone can see that properly. And you know, the focus here, there's so many different topics, obviously, with respect to concussion, and my focus will be returning to athletics. And athletics for people may mean different things. It may mean recreational athletics, it may be returning to school, it may be returning to high performance sport. But the reality is when we're talking about athletics, you know, going back to participation in activity that you deem of importance to you with respect to movement. Some important disclosures just to kind of acknowledge. The main thing in terms of my affiliations, my home base is the University of Toronto in the Faculty of Kinesiology and Physical Education. I'm also connected with our Macintosh clinic that's within our faculty at the university, where our priority is varsity athletes or intercollegiate high performance athletes, as well as community members. And you know, really our focus is acute injuries and concussion being one of those focuses, and obviously sustained through any sport or physical activities. Also, as noted, member or director of the Center of Sport-Related Concussion Research, Innovation, and Knowledge. That's a consolidation of different members across the university that are helping to try to solve this important puzzle. I'm also a consultant with the NHLPA, and how that may be relevant here this evening. I'll probably just kind of share some of our research findings at the high performance level that is publicly available in peer-reviewed applications. But what's really interesting in this context is that it's a really great clinical research bed of information. Obviously, there's 900 or so professional athletes, but they all have very sophisticated, comprehensive medical staff. The focus is obviously important for the league and the Players Association. And so we're really trying to understand how to improve policies, how to improve management, and have the best available care to these athletes. And the last thing to acknowledge is commercial interest. It's not really that relevant for today's talk, but I think it's still important to acknowledge that I am affiliated with a University of Toronto startup company that has the role of actually trying to provide rehab solutions digitally for concussion and mental health. And so, yeah, that's that. So how do I want to spend the next 20, if I look at the clock here, 25, 30 minutes? I think it's important that I just kind of make sure that we're all on the same page. I call it the concussion primer, making sure that we would define what we're talking about, understand the important characteristics around concussion. Some of those that you may already know, but some of those may be gentle reminders, and hopefully some of that's new knowledge. I will then kind of go through what's important for acute management. And when we mean acute, we're talking about from the time of injury for the first 48 hours. Given my talk is on what's return to athletics, I think it's really important to acknowledge what is unique to sport. And that may be different from school, that may be different from occupation or work. And also what's unique to return to activity. And what I want to end with is kind of talking about the different phases of concussion recovery and how we would want to manage that with respect to returning to athletics from different healthcare professionals. And then hopefully, for sure, we'll leave a fair amount of time for discussion, right? Because I think that's also the important piece of a session like this evening. So to start off, let's just appreciate what concussion is, and I actually I find this diagram figure quite useful. And we often say that concussion is the injury of individual differences, or another way to look at it is that concussion is multifactorial. The main thing, let's start in the center. The center would be that kind of rapid head acceleration that causes neuronal disruption, causes ionic shifts, energy disruption, all those things that then produce symptoms related to that concussion. Dominant or kind of common symptoms that people would be familiar with, maybe feeling nausea, headache, pressure in the head, dizziness. Sometimes if you watch high performance sport, you'll see like motoring coordination, or they're kind of in a fog. There's also affective issues. So, things around sadness, anxiety. People can also have sleep issues. Sleep's an interesting one because sleep goes in either direction. Some people all they want to do is sleep, and others have a lot of trouble sleeping. The other kind of category that's important to consider is like sensory items. So sounds, loud sounds seem to be disruptive for people, or bright lights. Often people say that the lighting's too bright. So there's a whole bunch of different clusters of symptoms, and that's really at the center. That's called at the center. And then the next ring in yellow is what we say comorbid. So why that's important is that when you think of common mechanisms of concussion in athletics, someone may get struck by an elbow in a sport. If they're jumping up for a basket and they come down, they elbow someone. In soccer, maybe if they go up to try to head the ball and their two heads collide. If it's hockey, maybe they collide purposely if it's a body checking league, or maybe they fall and they hit their head in the ice. I'm describing different mechanisms, but nonetheless, head contact is often associated with that. But when there's that rapid head acceleration, obviously what's connected to the head is the neck, and comorbid, or things that happen at the same time as concussion, is often neck issues. And so you may have, disruption to the actual vertebrae that may need issues, ligament, musculoskeletal, but nonetheless, that sometimes can be something that happens at the same time. And technically, if it's a real bad accident, maybe they also separated their shoulder, maybe they fractured their arm, whatever that may be. And the last ring is to identify premorbid issues. And premorbid is, what does the individual bring into the injury? And so that would be situations, sorry, I'm just making sure there's a chat there. That wasn't for me though. And let me get that out of the way. And premorbid issues would be, common for concussion would be like, how many concussions did they previously have? Is this their first? Is this their fifth? Do they have a history of migraines? Do they have a history of anxiety, depression? Do they have sleep disturbances? Do they have certain personality characteristics? Everyone has a personality characteristics, but everyone brings something into an injury. And so if you can just visualize yourself, all these different factors, the type of symptoms you have, the comorbid issues, the premorbid issues, everyone's going to have different kind of volumes of these rings. And that's how you can kind of visualize that the concussion is the injury of individual differences. The last thing I kind of want to say about the concussion primer is head contact. So if you look in the general consensus statement, you will say you have either direct or indirect. So direct head contact would be pretty straightforward. You get punched in the head, elbow the head, you fall and hit your head on the ice. Those would be simple examples. Indirect would be, like a kind of a mechanism. Maybe you're in a car accident, you you come to a stop quickly. Nothing hits your head, but you come to a rapid deceleration, and those forces then produce kind of neuronal disruption. And so that's what we say is indirect. So it's possible, but we've looked at this actually in hockey, professional hockey, through very sophisticated video analysis. And this is only one sport, but nonetheless, it's not very often that head contact is not involved at some level. Even if the clinical notes say no direct head contact, we look at the video and they're actually, maybe they hit their head on the shielding or there was contact. So despite it possible, I would say 98% of concussions involve some head contact along the sequence. The other maybe misconception is that if I've had a concussion that, I must have memory gaps, or maybe I was knocked out, or that's not the case. It actually happens, the memory gaps, either before or after being hit in the head, is probably about 1 in 4. And loss of consciousness in the sports context is probably at most 10%. So in reality, a lot of concussions, people have full memory of the event. And so what are we relying on? We're going to have to rely on how they feel or how we observe them. Standard neuroimaging, so if you went to a hospital, CT, MRI, that's going to be normal for concussion. And so really we're kind of dealing with the clusters of symptoms I first described: cognitive, physical, affective, sensory, and sleep issues. The other kind of misconception around concussion, or not misconception, but something that I would like to try to clarify is, if I fall back on my chair here and I hit my head on the floor, like, when should I start feeling symptoms? Should it be like right away? Should it be an hour from now? Should it be 5 days from now? Let's say for right now, obviously, most people are probably seeing me on the screen. If I fall, I will likely be quite embarrassed and probably almost in shock, and I may not have symptoms right away. Just that kind of like visceral emotional response that maybe I may have this kind of this rush, and maybe I don't have symptoms right away. But we leave the Zoom call and I kind of calm down. And it's like, oh man, my head really hurts. I have a headache. So maybe an hour later. Now, what happens if I don't have any symptoms and 5 days go by? So it's now, let's call it Sunday, and I get a headache. Is that connected to this event that I'm falling off the chair? Likely not. Likely not. When we look at symptom onset, a lot of the times it's within the first 24 hours. It's not going to be a week from now. It's not going to be 2 weeks from now. Sometimes you'll see a lot of kind of documents say that, a few days later, they potentially, it can happen, but it's a pretty rare occurrence. What's often necessary for symptom onset is kind of just having that stress on the body, whether you go to work, whether you go to school, and you're like, oh, wait a second, I'm having trouble kind of like focusing, following things, conversation. And that should occur anywhere from, 10 minutes after, probably 48 hours. Once we get beyond 48 hours, that happens far less. Now, if you have that injury, when should you feel better? If I'm just talking about the athlete, the run-of-the-mill high school athlete, university athlete, professional athlete, that runs anywhere on average between 2 to 4 weeks. Now, that's the average, and the average is not very good for concussion. And we actually know that up towards the 30% of people actually have symptoms longer than a month. And then we also know that 10 to 15% of people have symptoms for longer than 3 months. So unfortunately, you're given the diagnosis maybe 2 days from now, and you can go from anywhere from like 2 weeks to over 3 months with the same diagnosis of concussion, which I think is a disheartening experience for a lot of patients, because we can't be definitive of whether you're going to fall into the 2 to 3 weeks or the 2 to 3 months. We have some kind of markers, but I wouldn't say they are perfect in precision. So nonetheless, 2 to 4 weeks on average, we would expect full recovery, but we do have a subset of people that can have weeks to months of recovery. So what would be the generally accepted principles of within the sport context? Or I guess generally any concussion, but let's stay within the sport context. First and foremost, let's say you're in a hockey game and the player gets hurt, suspected to hurt, they're going to remove them from play, and they're not going to want them to kind of do anything for the first 24, 48 hours. You want that kind of settling into making sure that obviously if they return to sport or any activity, they're going to be at risk of re-injury, and that could be quite damaging. But you also want to understand what is that kind of level of the symptoms. If we know that if people continue to do things right after injury, it can actually heighten symptoms or make things worse. And I don't want to spend too much on the neurobiology of this, but what happens in this situation is, think of like you knock all the books off a shelf. Your brain needs that. Like the books haven't ripped up and gone to shreds. They're just disorganized. And so you need that time to get the books back up. Now, what's interesting is our body has this inherent reaction to actually provide less blood flow to the brain in the acute setting. So how do I move the books back to the shelf? Well, I need energy. And how do we do that with the brain? Well, it's going to be through blood flow. And so really what we call this a metabolic mismatch is that I need energy, but it's not being provided. So that can make symptoms worse. And so that's why we say, listen, your brain needs time to relax and rest, and making sure to do that for 24, 48 hours. Years ago, and I'm going to go into this has shifted, that rest used to kind of be prolonged until someone feels better. That is no longer the case, and I'll go into why that is the case, not advised, because what happens is if you have symptoms for 4 to 4 weeks or 2 to 3 months, and you're told not to do anything if you have symptoms, well, then you have deconditioning issues, social isolation, psychological issues. And so those old school management principles have turned out to be worked out as well as originally intended. So you only rest 48 hours. Then the biggest piece, sometimes I don't think it gets enough credit, is education. And the education should be provided by the medical provider. And what you're doing in this situation is, when you're in concussion, you're obviously aware of everything, but a lot of times, a patient has been told that their brain has injured or they have a concussion. So, it's a bit of a sticker shock, so to speak. It's like, oh my God, it's a concerning issue because everyone needs to take care of their brain. And so it's important that practitioners educate patients on, what, you can have these whole realm of symptoms. You could be like irritable, like your spouse, girlfriend, boyfriend, they could really piss you off. And that could be actually irritability, a symptom of concussion. You could sleep a lot, you could not sleep at all. You could have trouble with lights and sounds. And so it's the role of the practitioner to let them know that the majority or the diversity of symptoms that are possible for concussion can occur. And it's also important that, what should they do in the future? How should they go about over the next couple of days? What red flags should they look for? There's a lot to kind of cover, but nonetheless, it's really helpful for a patient to normalize the injury, to understand what's expected, to potentially be aware of red flags and do's and don'ts. And so that's a real important piece to the initial management. Now, what's unique to athletes in return to athletics? I guess I could say athletes are special, potentially, but nonetheless, the context of the environment of athletics and athletes is unique. And the one thing is that a young, high performance, high school, grade school, their identity is often tied to what sport they play. I have a kid in grade school. You can see like they wear certain jackets that they play sports with. They carry their basketballs in their arm. A lot of young kids in high performance kids define their identity through sport. And so that's an important thing. If they're removed from that context, it's a shot to their identity. It's potentially disruptive in how they define themselves. And as you get higher and higher on that performance channel, it becomes even more and more important. The other piece is that if you take a young athlete, a high performance athlete, someone who's very accustomed to being active, and you take it away from them, and so they're no longer doing what they feel is normal, whether it's like working out, whether it's practicing, whether it's training. A lot of athletes need that cathartic experience of doing something to calm themselves, to sleep better. And so when you take that away from them, that seems to be a little bit more complicating than someone that is not, constantly involved in athletics. And the last one there is peer support. And that's also maybe tied a little bit to identity, is that your peer support group is often defined by the teams you're with, the players, the people you train with. And so again, if they're not with those individuals, how do they get that social interaction? How do they get that help? And how do they help normalize that experience? And so those are real kind of unique aspects to athletics and return to sports. So, let's kind of move beyond the first 48 hours and move into reintegration. And this is I put this up here not to like provide a poor slide of just a big table with a lot of words on it, but this is just to kind of show you that comes from the consensus statement of concussion in sport, to say this is what the return to strategy or return to sport strategy or return to athletics should look like. And I'll point out is that each step typically takes a minimum of 48 hours or 24 hours, sorry. And you start with symptom limited activity. And then your next stage is aerobic activity, which is 55% of your max heart rate. And then you move up to 70%, and then sport specific drills, and then non-contact training, then full contact practice, and then return to sport. So it's you can look at this and be like, okay, I have to bike slowly, I have to do certain training and drills, I have to kind of ramp it up. Someone who just gets this for the first maybe time or kind of applying this to a patient, it's not the easiest thing to translate, to be quite honest. So I'm going to take a stab at trying to simplify things and, really think of it as layering the cake. So we're going to have 3 layers of the cake. And we're going to, those different layers are going to be physical, they're going to be cognitive, and they're going to be sensory. So those are our 3 layers. And to start off, our first layer of the cake is going to be physical. So what you want to do in the first kind of phase is just test the cardiovascular system. In a way is that if we increase the heart rate, so we're not going to have bright lights, we're not going to have loud sounds, we just want to increase the heart rate. That's often maybe achieved on a stationary bike, a treadmill, and so we're seeing, can that make people worse? Because if the idea is that if we stress the cardiovascular symptoms and they get headache and they feel foggy and they get nauseous, that is a potential indication that there's incomplete recovery so far. But let's say they do that well. Then we move into sport specific. So bike, treadmill, whatever that may be, that's benign to agnostic to the sport that they want to go back to. But let's say they want to go back to basketball. So then sport specific movements. Well, what are movements for a basketball player? You're going to still say physical. So I think in basketball, well, I need to run, I need to cut. Okay, so go do that by yourself. Jog and then cut, turn, pretend you're catching the ball. Don't catch the ball, just pretend you are. So you're kind of now moving in free space that is specific to the sport that you're returning to. And this is really kind of second nature to a lot of athletes. So I'd say we're still in the physical realm. Then the next phase is sport specific drills. We're going to add a layer of cake. So we've gone from 2 physicals. Physical is not moving in free space to physical moving in free space. And now we're going to add cognitive. So now you're playing basketball, you're cutting, but now you have to make decisions. Maybe you have to pass to a teammate. Maybe you have to receive a ball and then turn and pick a basket to shoot on. Or maybe you have to do bounce passes. So you're adding some cognitive decision-making to that process. And let's say that goes well and there's no symptoms. Then you move into sensory. And so now you have all your teammates around, you have the bright lights, the loud sounds, the whistles blowing, but we call this a controlled risk practice. You want to try to limit the risk of re-injury as much as you can. And so those would be those different layers. of the kick. And each time you want to wait 24 hours before you go to the next one. So realistically, in best case scenario, if you rest for a few days, 2 days, and you start the process of return to play, an athlete can't get back faster than a week. It's really that would be the kind of aggressive return to play. So I would say bare minimum, you have a concussion, you're likely out at least 7 days if everything goes well with the return to play process. Now, the one point that I want to hone in on is how do you start off? Like, what's the best way to start off on aerobic activity? Do I run around the block? Well, no, you don't run around the block because you have to deal with, obviously right now, ice or issues, but there's cars, there's people walking, there's sidewalks. And so believe it or not, there's a lot of sensory stimulus. And so the research initially said, you know what, let's control this on a treadmill. And we'll start off on a treadmill. And that's originally, if I go back in time about 10 years ago, they thought, well, we also need to determine how intense that should be. And you know, the University of Buffalo group is probably credited, and rightfully so, credited for a lot of great work that they said, you know, what you should do is you should figure out when symptoms begin and take just below that as the starting point. They made a lot of great advancements in that space. But one thing that, you know, we started to challenge a few years ago at the University of Toronto is like, do we actually need to actually test anyone before we advise return to activity? And, you know, this highlights in this study is that instead of actually doing any exercise testing or using a treadmill, we started to say, can we just hop on a stationary bike and just based on how old they are, make sound exercise prescription kind of heart rate targets? And we showed that to be very effective. And so not to, based on time here, I'm just looking at time. Green is the people that did the exercise protocol, and purple is actually those that were just advised to start their activity, which we call usual care. But this one, we actually made sure people did it, and we found to be quite effective on getting people recovered faster. So that highlights the point that early introduction of aerobic activity is really important. So we've kind of moved from you should potentially consider a very prescribed, what we call sub-symptom threshold, to using just heart rates as a general paradigm of like starting off at 55, 60% of your maximal heart rate and getting on a stationary bike or a treadmill. One thing that we challenged potentially, or we asked ourselves a couple of years ago, do we even need exercise equipment? Do we have to use a treadmill, or do we have to use a stationary bike? And this is just a study that we did, now published a couple of years ago, is we actually got people just to like squat, do lunges. And again, we kept them stationary. So we didn't have them running in a free space. We kept them in a single area. And we delivered this actually through a mobile app where we said, okay, just can we get you to get to that aerobic stimulus by just moving your arms, squatting, lunging, doing all those things? Again, not to belabor this point too much, but let's get, based on time, let's just look at this purple band here. This is between 55 and 65 of their maximal heart rate. And you can see that these are individuals, these vertical bars. Most people got to that spot. Some people got lower and some people got a little bit higher. But nonetheless, we had feasibility that, you know what, you don't actually even need to get on a stationary bike or get on a treadmill. You can actually just move in a way that lunges, squats, arm raises, that provides that stimulus. Again, giving some options to people to look at return to athletics and aerobic activity. And what we also found in this situation is that irrespective actually their heart rate, everyone actually felt better after doing it, which was an interesting finding. Okay, so I've really kind of spent most of this time really talking about these two spots here, acute and subacute. Subacute is after the first 48 hours. Now, where things potentially get a little more complicated is the persistent symptom group. And this would be in individuals that have symptoms for maybe more than a month. more than 2 months, 3 months. So their symptoms are not going away. They're persisting. And so how do we manage those people? Do we just tell them to just keep staying on that stationary bike? What can be done? And so, yes, in the early phase right here, our main focus is often just return to aerobic activity, treating comorbid issues. Like if they had a neck injury as well, we manage the neck, but you're not really doing too much at this point. Minimally invasive kind of interventions, reintroduction of stressors. Now, that changes when we get to persistent symptoms. And this is a very busy slide, and I realize I only have 4 minutes left based on my 30-minute time allotment. But let me try to kind of walk us through this. Okay, so let's just take this half of the slide: calcium, potassium, glutamate, glucose, cerebral blood flow. And this here, the y-axis, is percent of normal. So this means more, and then below 100 is going to be less than normal. The x-axis here is time. And this is a well-documented model developed by Gies and Hovda, originally developed in animal models. But let's just stay on the left-hand side. In the acute and subacute phase here, we have a lot going on. Glutamate is an excitatory neurotransmitter, which then has a catalyst for a number of ionic changes. We have shifts in glucose metabolism. And then this red line is a decrease in cerebral blood flow. And that corresponds to what I previously said about the neurometabolic mismatch. We have a bunch of things go up, books fall off the bookshelf. We need to get them back. However, we have this like reduction in cerebral blood flow. So that's kind of that piece. Let's say that all resolves. Let's say that all resolves in 10 days. So everything normalizes by 10 days out. Well, what about the people with persistent symptoms? What about the people that have symptoms for months? Well, we're starting to realize that the old graph didn't include these three things. And so this is a kind of updated within the last kind of couple years. And we're starting to realize that, you know what? Some individuals have increase in inflammation. There's demyelination. There's changes in neurotransmission and neuroplasticity. And not to say that all three of these characteristics define what's in persistent symptoms. My point here is that we now acknowledge that changes can occur that don't resolve within 10 days, and we can potentially have other concerns or issues that potentially need treatment and consideration. Now, how does that look clinically? So here, the different colors, I think, is what we refer to as often in clinically as different phenotypes. So when we talk about concussion as individual differences, people with persistent symptoms usually have a dominant cluster of symptoms. So maybe some patients come in, they're like, I really just have a lot of trouble at work, thinking, doing my cognitive tasks. Some people would say, you know what, I'm really anxious, I'm sad. So that may be their dominant profile. Some people may say, I have a lot of sleep disturbance. And so you're going to have a dominant profile based on persistent symptoms. Now, below this, which is potentially helpful, is that these are common intervention opportunities. So if people have anxiety and depression, well, we know that cognitive behavioral therapy is very good. Psychotherapy, exercise is very good. And maybe potentially medications. And people with maybe dizziness, maybe it's vestibular treatment, maybe they need to potentially treat an underlying migraine and autonomic evaluation. Well, what about people with sleep disturbance on the left-hand side here? Go through the considerations of sleep hygiene. What is their setting in terms of like habits before they go to bed? Do they potentially have cool rooms? Do they have caffeine? All those things. Maybe melatonin would be helpful. Sleep study. And so what you do, what physicians would often do clinically is try to determine what's the predominant symptom cluster and start treating that as a potential, first line of attack. Because, like I say, with the injury of individual differences, persisting symptoms after concussion is not, they don't all look the same. And so they may be struggling with different issues. And this is where the precision and expertise of a health practitioner is going to try to figure out, okay, what can we tackle one at a time here to be the best value of opportunity for intervention? I think often what we do clinically is we say, okay, these are your symptoms, but what is your worst symptom? Or give me your 3 worst symptoms. And then really you just try to treat those aspects. And so different professionals may be different required, whether it's a neuropsychologist, occupational therapist, whether it's a physical therapist, the list goes on and what's possible and for dealing with those things. But that's why often in people with persistent symptoms, you're dealing with a multidisciplinary or interdisciplinary healthcare to help target those issues. I think the main thing that I want to take away from this is that they are all realistically treatable. And I think historically, maybe if we backed up like 10, 15 years ago, there was this idea that it wasn't treatable. And I think a lot of the kind of leaders in the space now recognize that this is not a dire space, and that if you focus on some of the symptoms that are giving people trouble, you can definitely make inroads in treatment. Okay, I think I'll stop there. I am 2 minutes over, but I try to do my best to stay within 30 minutes.
Thank you so much. I'm going to jump into questions. We actually had a couple in the chat. So we had Janica was asking about the chart, the return to athletics chart that you had shown, asking, is it the same as the CAT online PDFs?
Very similar. So I say what CAT has done, and they've done a very good job. They've made it a little more digestible to, I would say, the general public. The one that I showed you is a really much verbatim screenshot from the actual consensus statement, and CAT has done a better job at kind of making kind of the graphics or the visuals a little more digestible to the to lay individuals, I would say.
Right. Next question. What is demyelination, and how do you actually know there is demyelination?
Yeah, so, myelin helps to kind of stem communication between neurons. And so demyelination is the loss of integrity around that. And how we know that is that in probably the last like 10 years, there's been a lot of studies that looked at using called advanced neuroimaging. Diffusion tensor imaging is probably the most common modality, and that's where we have recognized that there's potential some demyelination, and also there's probably some other techniques, but that's probably the most common. Now, I will kind of like have a bit of a caveat on this, is that we have identified some of these things in some of these I'll call it advanced neuroimaging protocols. I don't think we're all as convinced that one, they're permanent, and two, that they are going to be a situation that is detrimental. So what is amazing is we have tons of cells in our brains, billions. And so because things change, we are constantly changing. We're a dynamic kind of system. And so because you see one change here, we can adapt in other ways. And so because you observe something doesn't mean that it may kind of 100% change behavior. In the most extreme sense here, if people lose their sight, all the other senses go up off the charts. And so we just have to appreciate that our brains are also very dynamic, and we may be able to kind of change, mitigate, or alter that experience. So because that occurs doesn't mean that it's necessarily detrimental and a permanent behavior change.
Okay, that's great. Thanks so much. We've got another comment. 6 weeks after concussion, feeling fine, except when I jog, I get a headache. Aerobic exercise alone isn't the problem, saying they're an avid tennis player. Yeah, I don't know. Any comment on jogging and headaches post-concussion?
Yeah, there's a few things, right, that I think often when I hear jogging, uh, except aerobic exercise isn't the problem. So when I think movement in space, even jogging itself, you're having these kind of micro movements, and so you are going to have head movement. And so headache, I'm not a headache specialist, but often headache is there's a lot going on in headaches. It could be like, what are the triggers for headache? What's the sensation? Is it around the temple? Is it around the top? Is it the top of the head, the back of the head? How does that come on? What's the magnitude of that headache? How long does that headache last? So headache is it's got a lot of tentacles, to be quite honest. But nonetheless, when I hear people say that they accept jogging or they feel fine except jogging, I often, my first thought is neck. Is the neck stable? Is it potential running mechanics? Is it potentially just where they're positioned on the neck that they're causing a little bit of stress and tension? And so, without kind of going into too much details there, often when I hear people, they say headache and jogging, I think neck, um, assuming that, when you kind of get your heart rate up on a stationary bike or something like that, you don't get a headache. That's my first initial thought.
Mhm. Okay. Oh, and just adding to that, is there any issue with jogging and
Mhm.
damaging the brain?
Yeah, that's a good question, and to be honest, it's a common one. And let's kind of think of just dealing with persistent symptoms. So I would not say this 24 hours after injury, but for 6 weeks after injury, it's a situation that there really isn't any biological rationale to say that aerobic activity or vigorous activity is going to damage the brain from a biological perspective. You may get symptoms, and this is what I tell people, patients, like you may get symptoms, but I don't think you're damaging your brain. And so we really have two avenues to go down. We can not do activity and just wait to see if they go away, or we can take what's called the progressive overload approach, where we try a little bit, see if you can tolerate, back off, and then go forward again. And that's sound rehab principles like knee, neck, ankle, shoulder. You do your exercises like, oh my God, my shoulder. It's like, wait a couple days. I was like, do it again. Right. And so you're trying to build up that tolerance. And usually when people have symptoms for weeks, if not months, we take a very similar approach, like reintroduction of exercise, but in a progressive manner. And if the symptoms are present, and let's say they go away for 30 minutes, 45 minutes after exercise, I take that as a little bit of a win. And because you know what? You've done it, the symptoms have gone away. Let's try again later on. Now, if you do it and you feel unwell and you can't go to work for the next 3 days, that was probably the wrong approach. But it's about, well, I had symptoms in 2 hours after exercise. And then the next time I did it, I had for an hour. And now it's only half an hour. So we're trying to build that tolerance. And so, you know, assuming that there's no under other issue besides concussion, I do not believe you're damaging your brain 6 weeks after concussion.
Great, thank you. Has there been any research interest in using the activity protocols from your studies with concussion patients who are not athletes?
Um, so the one study that I shared with you on the mobile app, that was actually not an athletic sample. I probably, if I had a little more time, I'd kind of dig in a little more about that one. We did that study during COVID, which we weren't allowed any in-person testing. And so we did online recruiting. And for the most part, these people were people with persistent symptoms, not from sport. And so to be honest, I got excited in that space because, if you tell an athlete to squat and lunge, it's like, okay, that makes sense. They know how to do those things. But we were able to actually show feasibility in actually having people who are not commonly know these movements. However, I took it from the perspective, you know, everyone knows how to squat. Like you may not believe it, but you know what? On day-to-day operations, you get up out of bed, you go have coffee, you go sit in your car, you're probably doing about 50 squats in a day without you even knowing it, because that's how you get up and out of chairs all the time or from sitting. And and so we took very sound movement principles in just general activity, general movement principles. So not sport movements, but general movement principles for health. And we applied that to a non-athletic setting. So we actually have shown to have positive results in the non-sporting setting, particularly around that protocol, which is exciting.
Great. And there was a question just about you had mentioned an app. Is that
Mhm.
something that is available
It is
publicly?
actually it is available. We're actually kind of just went through another round of like iterations or improvements. We did a study with actually Ontario Brain Institute, and we did it with another 100 individuals, and we got some great feedback from users. And we're continuing to kind of improve. Yeah, so if you would like to have access to it, yeah. If did I share my email? Is my email associated with this presentation? If you want to email me, I'll send a link, and you're welcome to use it for free. At this point, uh, we're still trying to figure out what works, what doesn't work, and we're still accessible. But at this point, we're just people have to reach out to us to get it. So you're welcome to email me, and I'm happy to provide. And that's for anyone that's potentially on this webinar.
Okay, thank you. Um, let's see. Without having a protocol for cumulative, so this is from Sarah. She's had cumulative sports injuries over a bunch of decades. My last swimming concussion has resulted in persistent changes in my memory strength. And wondering, is this sort of a too bad, tough luck kind of reality for her? She says she's still an active athlete. I'm not
Can you
sure when
repeat that
her
one?
last concussion was. She said her last one was a swimming one, but it sounds like after the last one, there's been some memory change.
Um, where is this on the chat, Leslie? Sorry, can you direct me just so
Oh,
I
this
can?
is in the Q&A.
Oh,
Sorry,
okay.
there's kind of questions coming in on both. It's from Sarah in the Q&A.
Do you mind just kind of repeating the question once more? I
Yeah,
apologize.
yeah. So it sounds like Sarah's had many sports related concussions over, she says, a bunch of decades. She
Yeah.
said her last concussion has, she's now had persistent changes in her memory. And she's wondering if this is, whether she's going to continue to deal with this or whether this is something that's likely to resolve. It's kind of a hard.
Yeah. Yeah, no, and I will say that the cognitive symptoms are I find the hardest to treat actually. Well, I'm not a neuropsychologist for one, that probably contributes to it. But nonetheless, I do find in the athletic population that one being the little more difficult to treat. Now, what I will say is that I would say a lot of the times I've seen athletes that have had 5, 6, 8, 10 concussions, and they have symptoms, and eventually over time it does get better. They may not return to sport for those decisions, for various decisions, but we do generally see again changes. And sometimes what we find is people may think they're having cognitive troubles, and I think this is where the neuropsychologist will come into play sometimes, is maybe you need a clarification, maybe an assessment to maybe quantify what those problems may be. But I've also seen success on the other hand, is that people have had multiple concussions, and I'll just share a brief experience around this. People have had multiple concussions, and there's a lot of negative news around concussions. Like if you talk about CTE or these issues, you can get very kind of down a spot where it's like, oh, this is not very good. And sometimes what we'll do is we'll do testing with people. They have these complaints. They'll have subjective symptoms, and we'll do testing, and they'll be working, and you show them that they're actually above average compared to most people. And it's like this a little bit of a oh, like an aha moment. It's like this is this relief to know that yes, I have symptoms, But if you objectively evaluate and you do that in a very controlled way with a professional, one, you can quantify what those issues are and come up with strategies around that. But the second thing that happens, they actually come back looking pretty good, and it's almost relief for them. It's like, wait a second, I'm actually not having that much like, and so I'm not going to say in your case what's happening, but I'm saying that there's opportunities to potentially see a professional to maybe quantify those issues. But sometimes those symptoms don't match actual performance. I see that often in students that they say, I'm having a lot of these cognitive issues. And I say, well, how are your grades? It's like, 85, 90. What program you're on? U of T engineering. It's like, okay. That's like top 1% in Canada for your age group. It's like, you may feel a little bit different. You may have symptoms, but cognitively, you're very sharp. And occupation or school are very good kind of barometers of those things.
Yeah.
Sorry, that was a long-winded answer. And
Yeah,
Leslie,
no, that's
you're an expert in this. I don't know if you have anything else to
right.
share in that space.
Yeah. Well, I think there's always, when I am seeing people, there's so many, just as you talked about at the beginning during your primer in terms of concussion being such a multifactorial, there's so many different things that can be going on. And certainly in terms of cognition too, in terms of different, is the person sleeping? Are they having, some mental health kinds of challenges? So, okay, I'm just sort of monitoring the time here. And Susan is asking, is there a rule that if your activity or day increases symptoms, so I guess if you are particularly symptomatic, should you then rest, say, for 24 hours until your symptoms go away and then try the activity again?
Yeah, to be honest, that's pretty much bang on.
Yeah.
So if it's a situation that you kind of do an activity and your symptoms are provoked and you don't feel great for a couple hours, it's best to maybe take the next day off and then start again after that. So to wait 24 hours, have a good day, get a good night's sleep, get some nutrition, making sure you're level set, and then try again. If your window starts to decrease, maybe it's only 15, 20 minutes, half an hour, then I would say you could probably go the next day. But as a rule of thumb, without kind of working with someone on and closely monitored, 24 hours rest between symptom provocation is a very good rule of thumb.
Fantastic. Just a quick comment on there was lots of curiosity around your email. So your email is actually on the last slide, michael.hutchison@utoronto.ca. But just FYI, also the slides will be posted probably within about a week on the website as well. Just to clarify, can you return to contact sports once the concussion symptoms are gone?
Can you return to contact sports once the symptoms resolve? So, no, sort of. Let me try to answer that. So, let's say your symptoms resolve after 5 days after injury. Okay, so let's say you get hurt on Monday, you have symptoms until Friday or Thursday, and you wake up Friday and you're like, I feel great. My symptoms are gone. You cannot go to that hockey game that night or basketball game. You have to then, or you still have to kind of complete those different stages of, well, I feel great today, so maybe I'm just going to go for maybe a little brief skate on my own. And if that goes well, I'm going to wait 24 hours, and then I'm going to have a couple teammates work with me to do that next layer of cake, the cognitive and the physical component. If that goes well, then the next day you're going to go into practice and have that controlled simulation, the bright lights and all those things. Then after that, once you see a doctor, you can return to the sport. So it's you want resolution of symptoms combined with completing the protocol. You can start the protocol introduction aerobic activity while you have symptoms though.
Fantastic. Next question. I am recovering from post-concussive symptoms. I've been swimming lightly, but got dizzy when doing the front crawl. Should I stay away from that stroke completely or try again?
Again, not a loaded question. It's a fair question. There's just a lot that needs to be considered in that. What type of symptoms? How long did you have the symptoms for? How long were you swimming for? Were there any turns involved in the swimming? You kind of would dissect that activity. Is it the motion of the front call and the head turning? Is it neck? So there's a lot going on there to kind of actually answer that accurately, to be honest. What I would say is, are you okay to, have attempted swimming? Yes, like that's not, you didn't make a bad decision. However, you may want to maybe just back up a little bit, being like, on reflection, how long was that intensity? Are you aware of what your heart rate was? How did you move your neck back and forth? Is it one way versus the other? If you swim the next time and you just keep your head in the pool, so to speak, I'm not a swimmer, so I don't know. I guess it's probably not impossible, but just even positionally is just lessen the head turning, making sure that you're not doing turnings on the side at each end. But generally, if you're a swimmer, I tell people that's your natural setting, and that's where you're comfortable in. I think there's no harm in using that as your stimulus. But if you continue after a couple of times, so if you do it again and you continue, I'd back up and get out of the pool. Try something where you control yourself on a stationary bike and see is it the cardiovascular element or is it the movement in space that's potentially contributing to those symptoms.
Great, thank you. Yannick is saying she's 8 years post-concussion, been dealing with post-concussion symptoms, feels like she's tried everything. She's referring to the pie chart that you provided and is saying the migraine, blood flow, dysautonomia cluster is the worst and is wondering where you might go next. She's also indicating she's in Edmonton. It's very difficult for us to make any specific recommendations, but do you have any thoughts on?
I think at that length of time and those types of symptoms, my first thought would be a neurologist. Referral would probably be the most appropriate, or rehab medicine. But I would say neurology would be a good starting place. I would say generally speaking, you'll have a hard time getting a bunch of experts in a room to say that concussion on its own would go on for 8 years. Secondary issues, other things that have complicated it do occur for 100%, but those are the aspects that need treated. And it's trying to identify what those issues are. And to be honest, I'd probably at that point, you want to making sure that you have, imaging done. You want to make sure you have blood work done. You probably want to see a neuropsychologist. You want to make sure you have, you can run through most of these professionals depending on those symptoms. But if that's your cluster that you're explaining, I'd start in neurology.
Thanks. Jeff has got a question. A sailboat boom to the head 27 months ago, no prior head trauma issues, and now constant cognitive problems, it sounds like, and noise environment symptoms that don't seem to improve. And just wondering if you have any thoughts on that one.
Yeah, what was it?
A sailboat boom.
Yeah, okay. So that's a pretty good hit. Again, it's a bit unfair for me to kind of even try to give you an accurate approach what to do here. I think the main thing, if I have a takeaway message, if you kind of go to that pie chart, is it kind of just having an honest kind of reflection for yourself, being like, what is the main issue here? Have I seek those professionals? And if I haven't seek those professionals, where can I find those professionals that may be able to offer me these interventions? I really would be like shooting the dark here to give you any better advice than that in this situation.
It's hard without a lot more information. Okay, I think I'm just going to ask one final question. We're right on time here. Emma is asking, How would you suggest dealing with recurrence of symptoms after they were initially resolving? So if I
Hmm.
guess if, they feel like they're doing well and then there seems to be sort of a worsening.
Yeah, that's an interesting question. I get this sometimes, and the way I explain it is, concussion recovery for the most part um, is a path where I don't know, I'll use my finger if that's even possible. But if I go back to the slide where it talked about the phases of recovery, there's like, okay, it dips down and then eventually it goes back up. That's generally the trajectory of concussion recovery. After concussion, it may not be right away, maybe a few days, but there's a bottom. There's a bottom where you feel like crap. And then generally speaking, over time, it may oscillate up and down. It's not this perfect line, but you may have a couple of days are good and then a couple of days are bad. And I often say, like, where is the trend going? Is it going up or down? But eventually, if it gets back to a point where things are improving, there's in concussion, like if you think of the neurobiology of the injury, there's no real good rationale why it goes back down without some intervening other injury or some other intervening medical reason. Because the way the brain recovers and what we know about concussion recovery, there's there's no good biological explanation to get worse again. That's just not how concussion recovery occurs, and it's just not how we understand the brain to resolve from concussion. And so if you have a situation, and this happens sometimes, people have a concussion, get better, feeling great, and all of a sudden, with no other intervening issue, they feel bad again. But that's likely something else. And I can't pinpoint what it would be, but there's likely another health issue. There's another maybe stress in your life. And that could be very um, transient. And it's something maybe be stress at work, or maybe it could be a relationship issue, or maybe it's just kind of like help dealing with kids. Who knows? There could be some other stress or event that then produces very similar symptoms to concussion: headache, fatigue, difficulty thinking, sleep loss, all those things. Now, the patient, his first response is, I'm recovering concussion. Those are the concussion symptoms. So my concussion's worse. But they haven't tied it to something else that may be at play that is producing symptoms very similar to concussion. This is the problem in the concussion space. They're not very good at actually describing concussion because there's none of those symptoms are unique to concussion. Difficulty thinking, fatigue, drowsy, headache. That runs the gauntlet of life. And so ascribing situations where you feel better and then you get worse to the distal experience of concussion sometimes doesn't make biological sense. Sorry, that was probably a little bit of a long-winded answer there.
No, that was great. Thank you so much. Well, I think we're actually over time. So thank you so much, Dr. Hutchison. It was a great talk. And thank you to everyone for all of your questions. If there were any questions that you didn't get answered, you can include those. There'll be a survey coming your way. It only takes a couple of minutes, and we really appreciate your feedback. If you do have any questions for us, just a reminder, if you want a response, just include your email in the survey, because otherwise they're anonymous and we don't know where they're coming from. And just a reminder, our next session will be March 11th, and we are going to have Dr. Firas Helrawi and Stephanie Cowell from Parachute, who are going to be presenting on prevention of subsequent concussions. So thank you everyone so much, and hope you have a great evening.